Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders, and I will be your organizer for this evening, and I would like to welcome you to our webinar on Outgrowing the Child Neurologist, Transition in Tourette Syndrome. Thank you all for joining us. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Brown answer the questions at the end of his presentation. We will get to as many queries as time allows. In addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would like to just watch it again, an archived version will be posted to our website. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill out the survey as you exit the webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, or objectivity or usefulness of the information presented. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Barbara Chabner, the Program Manager of NJCTS. Barbara?
Thank you, Kelly, and good evening, everyone. Thank you all for attending and joining us this evening. Lawrence W. Brown, MD, is Associate Professor of Neurology and Pediatrics at the Children's Hospital of Philadelphia, CHOP, and the Perelman School of Medicine of the University of Pennsylvania. Dr. Brown is a past president of the Child Neurology Foundation, and he currently serves as chairman of its Transitions Project Advisory Committee. This effort is defining the goals of successful transition for youth with neurologic disorders. He is the senior author on its first publication entitled The Neurologist's Role in Supporting Transition to Adult Healthcare, a Consensus Statement, which was published in Neurology with endorsements by the American Academy of Neurology, American Academy of Pediatrics, and the Child Neurology Society, in addition to the Child Neurology Society. Locally, he is a co-principal investigator of an epilepsy education and transition project funded by the Health Resources Services Administration in collaboration with the American Academy of Pediatrics. Dr. Brown is director of the Pediatric Neuropsychiatry Program, a multidisciplinary clinic for children with Tourette syndrome, high-functioning autism, complex ADHD, and genetic disorders, where complex learning and behavioral issues have a neurobiological basis. He is a principal investigator of a genetic study funded by the National Institutes of Health as part of an international consortium to develop a worldwide data bank of individuals with Tourette syndrome. Dr. Brown is also a senior clinician in CHOP's Pediatric Regional Epilepsy Program, where he continues to be principal investigator on numerous clinical drug trials in pediatric epilepsy. In addition, he is a senior clinician in the Sleep Disorder Center with a major interest in how sleep and its disorders interact in children with neurological and developmental disorders. Dr. Brown is an active member of the Child Neurology Society, the American Epilepsy Society, the Academy of Pediatrics, where he served 2 terms as chairman of the section of neurology, and the American Academy of Neurology. I could go on as Dr. Brown has many, many accomplishments, but I think I will stop there so that Dr. Brown can begin his presentation. Dr. Brown, thank you for being with us tonight.
Thank you. And thank you for that lovely introduction. There have been a few changes since because I'm currently on sabbatical, but all of the rest is more or less accurate. So can you see my slides right now?
Yes, we can.
Great. So let me get started, but before I do, I'd like to take a moment and recognize Faith Rice. Faith is an old friend, and we've worked together from the beginning of NJCTS, and it has been a wonderful ride together as she just went into retirement, and come June, I will join her, not directly, but we will be on the same page. And I think we can all thank her for the many years of energy and effort and success and growth that represents NJCTS. So let me describe what I'd like to do in the coming minutes. First, to review just a few things about Tourette syndrome so that we're all on the same page. Go through general transition and what it means, and why it's so much more difficult for those with TS, and then end with some of the barriers, but also some of the solutions that can improve what happens as a child becomes an adult. So let's get started with what we do know right now. And I'd like to just remind everybody what's happened with the latest iteration of the DSM, which is DSM-5. It hasn't changed very much, but there are a few minor differences. It's defined by multiple motor tics and at least one vocal mannerisms at some point. They have to be different, as I say, but it doesn't have to be daily. It can be intermittent as long as it's at least 1 year. In the past, one had to have no tick-free period for more than 3 months. That is now gone. It remains a pediatric onset disorder, and as we'll learn, it's often a pediatric resolution disorder. But if somebody begins having tics as an adult, one really has to look for a different mechanism. In the past, Tourette syndrome was less often, less common, less prevalent, and that was because the definition required that it produce significant distress or some difficulty in daily activity and function, whether it be in school, socially, or at the job. Again, that is now gone. And of course, in medicine, there are always other things that can look alike. And so it can't be caused by substance abuse. It can't be caused by stimulants, which it isn't, but that's another story we'll get to. And it can't be caused by some other medical condition. So even the latest DSM definition, if you just heard what I said, is limited to the tics and doesn't include any of the other conditions that often are at least as difficult for the patient and the family. So the best estimate of prevalence for what we now call Tourette, the chronic motor tic disorder, is somewhere between 0.1 and 1%. 1 in 1,000 includes the ones with impairment, but the upper limit, the 1%, 1 in 100, includes all cases of multiple motor verbal tics. Now, remember that the occasional isolated tic occurs in 1 out of 4 to 1 out of 5 children. This was observed by sending research associates into elementary school classrooms. And as I say, 1 out of every 4 to 5 kids had at least one tic on one occasion in the course of the school year. Another thing that people probably know, but worth mentioning, is that tics seem to go downward. They start often in the eyes, the nose, the mouth, and they progress downward. They also progress from the simple to the more complex, and the difference between that is the complex can be interpreted as something meaningful, even if it isn't. And the way that shows up is if you ask somebody who is turning their head, you say, "Why are you doing that?" And they say, "Well, I'm just looking around," even if that's not really what's happening. It's a good story. Even in 2021, why we have tics is not completely understood. Many people who have tics do have a family history, but not everybody. And from the tic genetic study that Barbara mentioned, which is also, by the way, very involved with NJCTS, the latest data suggests that new mutations, not that cause problems other than the tics, but new mutations that we can identify with the latest generation technology can be found in at least 25% of those people. I think everybody recognizes that tics are more common in males and in families where Tourette syndrome occurs. OCD is more common in the females. Why do people outgrow tics? We think that it's the maturation of the areas in the brain and the circuits that go through that area, the basal ganglion, that are completing their maturation at about the onset of puberty, that explains the tendency for tics to get better at that time. But I'd like to go back to the definition that says tics are defined, Tourette syndrome is defined by the tics and not by the other conditions. But there was a very large international study that suggested that over 90% of people who have tics also have ADHD or OCD or mood disorders, anxiety, as well as other neuropsychiatric issues. And these can be more difficult and more disabling and last longer than the tics. So for a little, I'd like to talk about some of the comorbidities. And ADHD is the most common. It accounts for about 60%. It often precedes the tics by several years. Tics often start 7 or 8 years of age. Onset of ADHD is typically 4 to 6 years of age. And remember, these are all general numbers and do not necessarily reflect the individual, but this is the most common. Although when I gave you the definition from DSM, it says it shouldn't be caused by stimulants, I'm absolutely convinced that while stimulants can make tics worse, can bring them out in people who are prone to tics but haven't had them yet. It only occurs if you're predisposed and it doesn't cause tics. And when you take the stimulants away, the tics get better. Tics are unlikely to get worse with the stimulants. Actually, only about 10% get worse. And the problem is, as everyone knows, tics wax and wane. And so therefore, if you have waxing and waning of tics and you start somebody on stimulants, they may or may not coincide with the waxing. Why do I even bring this up? And that's because when ADHD coexists with Tourette syndrome, it's the ADHD that predicts academic difficulties, even after you factor out learning disabilities and how severe the tics are. And remember, you don't have to have tic disorders. If you have untreated, poorly treated ADHD, that itself contributes to everything down the road, from an increase in car accidents to more smoking and drug use and challenges with jobs and relationships. OCD is the second most common with Tourette syndrome. If you just look at any ritualistic mannerism, it occurs in at least half of people with Tourette, and it can actually be very difficult to distinguish from the repetitive tic. But 20 to 30% will meet the full DSM criteria for obsessive compulsive disorder. The typical age of onset is a little bit older, 7 to 9. Remember that repetitive or ritualistic behavior can be age appropriate. Every 4-year-old gets into everything has to be Power Rangers or whatever the latest fad is. And some children are just shy, anxious, timid, and don't like change. But OCD is a problem with Tourette syndrome, and it can be hard to tell, not only from the tics, but with anxiety, depression, school difficulties, and just daily life. When we talk about OCD, it requires excessive time. It requires that there be distress and that it interfere with daily activities. Another fact which I forgot to mention was that for people who have OCD with Tourette, typically they need to repeat things until it feels right. When there's OCD without Tourette, it typically is because if they don't do it, something bad might happen. And so there's a difference in the meaning there. Those are not the only two major conditions. Anxiety is more common in people with Tourette syndrome. There are a lot of different kinds of anxiety, which you probably know about. Separation anxiety, social anxiety. We've seen a number of kids with selective mutism who can talk only at home or with a select group of close people to them, but not in public at school. There are phobias, and there's panic disorder. What I'd like to remind people is that when there's anxiety, tics get worse. And when tics get worse, they often become more anxious. So there's a feedback loop in both directions. When there's anxiety involved, the quality of life is impaired. I'd also like to mention, unfortunately, that mood disorders are more common with Tourette syndrome, and that it's often associated when tics are worse and there's functional impairment. Having depression, which is more frequent in adolescents, actually predicts psychiatric hospitalization. Quality of life is lower, and if tics don't go away, which they do in 2/3, it is an increased risk factor for suicidal thought and action. And the last thing I'd like to bring up before we move to the real topic for tonight is rage reaction, which is defined as being upset out of proportion to any inciting event and atypical of the baseline personality. It is seen in 20 to 40% of youth, particularly teenagers with Tourette, and more commonly when there is OCD and anxiety. It's been reported over and over as one of the most distressing and disabling symptoms, especially reported by parents and families. It increases the dysfunction, the social conflict, and the rage reaction is the leading cause for psychiatric hospitalization in children and teenagers. So before I move on, I just want to summarize and remind people that my opinion is that Tourette syndrome is a disorder that can be managed. It's not a disease that you can or necessarily want to blow out of the water and eradicate completely. What we aim to do is to reduce the tics and the comorbidities to the point where people can function and learn how to live with what they have. In general, people should not fear that the tics will take over their lives. Even when it's getting worse, they rarely cause major functional impairment or significant injury. They can, but they typically don't. So I say that understanding Tourette syndrome is always imperative, but treating it is not always indicated. And when we treat, the treatments are symptomatic and not curative. So when we make risk assessment balance, we have to think about that. When we have intervention that we feel is indicated, in general, where we've come to the consensus that cognitive behavior therapy ought to be considered as a first line, especially for mild to moderate tics, assuming that the child is mature enough and willing enough and treatment is accessible. For severe tics and where psychological approaches are not available, we do have, I believe, safe and effective drugs, FDA-approved drugs, and as well as off-label, which we can use. And when we use it, preferably, it should be in conjunction with the psychological approach. For those parents who are listening, I'd like to remind them that when a child has Tourette syndrome, parents should try to develop a team that is comprehensive and addresses all the needs, and a team that can speak among themselves as well as with the family and the patient. So you need primary care and a specialist. Although I'm talking about outgrowing the neurologist, there are some people who see their pediatrician, and there are others who see a psychiatrist, and it's all the same. Behavioral health might be indicated. Educational support with an IEP or 504 plan might be indicated, and when they're there, everybody really needs to be on the same page. The person who really needs to be on that page is the child, especially as he gets into puberty. They need to understand, they need to participate, and they need to, quote, own the plan. It's not the parent's problem, it's not the doctor's problem, it's the patient's problem. And lastly, I always think that it's so important to be optimistic, that we as doctors tend to see people when things are getting worse, but we know that if we wait it out, they often get better, and that the natural history shown over and over again is that most people improve over time, especially by mid-adolescence. And even if it doesn't, a positive attitude definitely minimizes the impact on life. Finally, we can now move on to transition. And what do we mean? We've just had a political transition. I told you about faith in my transition, but this is medical. And transition is a process that starts early and isn't over until early adulthood, that prepares the patient, their parents, their caregivers. So it's a process, not a moment in time. The moment of time that people often call transition is actually transfer, the handoff, when you leave the pediatrician and graduate and move on to the internist or the adult specialist. And it can look different for every patient, and it will depend upon the medical complexity. And in particular, we've learned that the biggest challenges if there are intellectual or physical disabilities that mean that it's unlikely to be able to be fully independent as an adult. But the goal of medical transition is to help those youth to take responsibility for the management of their own disorder and to become as independent as possible as their intellectual and physical disabilities would allow, and to avoid the cliff. I call it the cliff because once the youth leaves for college, once they graduate from special ed, and you can't go back and regain those years of progress and the resources that are available and are no longer after they become adult. So why are we focusing on transition at this point? Well, Obviously, growing up is inevitable, and we all want children and teenagers to be independent. Um, and why do we need to move on? And that is that even those with neurological and particularly neuropsychiatric disorders, it doesn't mean that they don't have general medical conditions that are better treated by adult doctors, whether it be weight or blood pressure or diabetes or whatever. Pediatricians don't do as well with those medical conditions. And if we don't do it early, it just doesn't happen. And as the expression goes, we just kick the can down the road. But I do want to remind people that transition is now a buzzword, and it's been accepted as important, and it's part of how we practice. But it's not easy. And I just want you to know that as a neurologist, I know that caring for any child with TS can seem like going through a long tunnel, and you don't know what's on the other side. But I really, after over 40 years of practice, want to tell you that there really is daylight at the end of the tunnel for all these people. We find it just as difficult to encourage people to move on as you do, because we've been working with you for many years. We've bonded. We feel like part of the family. But also we understand that there are big differences between what I call the pediatric comprehensive approach, which is so collaborative and reaches out to the school, reaches out in all ways possible, and a more narrow, focused, and patient-oriented approach that is the adult setting. And I have to be honest, because most of the patients with Tourette syndrome in childhood are followed by neurologists. There are very few adult practitioners who are comfortable and interested in these complex behaviorally challenged patients. And while this is not true for the majority of people with TS, if they have financial issues with limited insurance or intellectual disability, it's even worse with some of the other disorders that we care for. So I've been working on transition, running the program for neurology nationally for the last 10 years. And without going into great detail, this is what we've come up with. Not only did we come up with it because we based it on what general pediatricians and family practitioners taught us for primary care, but that it was necessary to actually begin the process long before it's ever over, and even before people are ready to think about it, by age 12 to 14. That's an age at which kids are capable of understanding, are beginning to have adolescent growth, and the issues are such that they can begin to process self-management skills and have increasing risks of behavior that we can address. They're constantly growing. I used to say it's like corn. You could put your ear to the kid and hear him grow overnight. So it needs to be reassessed at least every year. And remember that what's appropriate may change over time as we need to talk about driving or sexual behavior or drinking or sleep. If it's unfortunate and you need to have the discussion because of what used to be called mental retardation, intellectual disability, or severe physical disability, then trying to prepare for that legally is essential, because if you don't do it before 18, it's even harder. If that isn't enough, it takes time to match up with an adult provider. And so we ask for identifying that person at least a year before we complete transition, and that the transfer itself is only the last step, and it's only after it's successfully done and there's been at least one visit with the new person that we can say that transition is over and we can fully graduate. So just to repeat, it's a long process because adolescence is so challenging, and the dimension caused by Tourette and the comorbidities that I say is so common makes it more difficult. It really does take time to develop the knowledge of the disorder, the medications, the safety, the emergency plans, all these self-management skills, what you can do and what you need to avoid. I hate it when I was telling Kelly the other day about a patient who came to me. I thought I had done a good job, but called me up from college saying that he knew he wasn't supposed to drink while he was taking medication for the tics. But there was an important fraternity party coming up in a couple of weeks. So how many days before the party should he stop the medication so he could drink? I mean, we really need to help people to make good decisions and to understand the consequences of what happens when you don't. And it also takes time for parents and families to learn about what resources are available and how to access them while the child is doing well, hopefully. With Tourette, general transition issues make it even more challenging. As I said, tics define the disorder, but the comorbidities may be more disabling and last even longer, like ADHD and OCD. That all of these make adolescence in general more difficult. And in fact, mood disorder, emotional lability, aggression, and full rage reaction occur in virtually every youth at some point. So we really need to be ready and prepared. As I say, most teenagers will outgrow the tics. but that's not necessarily true for the ADHD, the OCD, and the anxieties. And even if it's all outgrown, or at least controlled, you can wipe the stripes off the tiger, but they don't always disappear. In fact, they rarely do entirely, and so you have to consider ongoing risk factors which can lead to more challenges in college or difficulty in maintaining relationships and raise the risk for smoking and other self-medication. And finally, I'm afraid that it's still true that there are very few adult neurologists who take care of Tourette syndrome, who take care of ADHD or other behavior disorders. And if these are ongoing issues, they often need to be followed not by the child neurologist, but by adult primary care or psychiatry. So if there are any practitioners in the audience, I would like to go back to some of the principles that we published and have been working on ever since, and that is the importance of a clear transition policy. It's not just the milk carton that should have an expiration date, but people need to recognize that a child pediatric office is for pediatric patients, and at some point they will outgrow it. We need to make sure that we can encourage the teenager to accept responsibility for him or herself and to learn how to advocate for their own needs. Remember, we need as practitioners to remind ourselves that you can't do this just once, but you have to do it yearly, to remember about the need for guardianship or power of attorney, where there are significant limitations, to always be sure that our patients that we're managing the Tourette syndrome have a pediatric or family practice or internist with them, that they're not using the emergency room for their primary care, especially important with complex patients. And one thing that I've learned is that this model of treating children as children, growing with them during adolescence, and making sure that they're treated as full adults is important, whether or not they stay with the same person throughout. Philadelphia and New Jersey are very fortunate in that we have lots of specialists, but in many smaller towns and rural areas and where there's poverty, there aren't as many, and so they may be seen by adult practitioners. And if you are an adult practitioner seeing children, you have to change how you treat the child and the family in order to achieve the goals of transition. For the parents who are here, and I think that's the majority, you can support transition for Tourette. You can support it by encouraging your kids to understand their condition, to identify what they should know about the disorder, what they should know about their medications, what to do in an emergency, and how to seek medical attention if it's indicated. But equally important is to encourage healthy habits, sufficient sleep, making good choices in terms of avoiding things and regular use of medication. In addition, parents who are listening would do well to think of their role with their kid as transitioning with them, that they don't always have to speak for the child, but they can also be their ally and encourage them to speak up for themselves. Parents need to remember that it's the youth's issue and it's not about you, it's about the child. And they may not make the same choice you make, and unless it's worth fighting over, it's probably worth giving them the space. I don't know that I can say that it's the same for everybody, and what I wrote is, I believe, true, that letting go will look different in every case, but letting go is definitely important. Now, I did say that there are barriers, and if you've been listening, you could probably think of the barriers. So let me go through a few, but make sure that you understand that we've thought about this and they all have potentially solutions. So for example, there's often a lack of understanding between the pediatric family approach and the adult patient-centered approach. We know that teenagers are often unaware or deny that there are consequences. And let's admit it, we often would be willing, I'm certainly know I can, to give up a part of my body to protect my kid. But I think that we have to try not to be overprotective. How can we improve things? Well, we strongly recommend that by the time of 12 to 14, the youth be given the opportunity to speak to the doctor at least for a couple of minutes without the family in the room, to learn how to speak up for themselves where necessary, to provide training to meet their psychological needs. And people who are on this call are very lucky because they already know about some of the local resources, and NJCTS can help them to connect with others, all of which should help to encourage the self-independence and self-advocacy. Another barrier is that the teens tend to not follow the medical plan. They are designed, teenagers truly are designed to be greater risk takers and not understand the consequences. And all of this is impacted if they have mood, anxiety, or OCD. Well, what can we do? Well, as doctors, we ought to be screening for these extra challenges. We can give the youth the opportunity to practice a brief summary of what they know about their condition. And something that we're just beginning to do, but I think will be increasingly accepted, is to get the most important information down on an app for their cell phone, or for those who are less tech savvy, on a flash drive, that give that information so that they can use it and refer to it. Now, among the work that I've been doing has been through the Child Neurology Foundation, which I was president of for a number of years. And we've put together a whole group of material that is open access, so anybody can use it. It's mostly designed for the practitioner, but it's available for families to encourage their doctor. There's everything from an official transition policy to the TRAC, the Transition Readiness Assessment Questionnaire, which is accepted and validated scientifically, that checks off the information that a child has achieved, is trying to learn, or hasn't even begun yet. So you can follow the progress. There is a self-care assessment that the youth fills out, or the parents fill out if they're limited. And then there is the transfer packet that is so important in making sure that there's full transparency from one practitioner to the other. The medical summary, I'd like people to recognize, should include the diagnosis and etiology, if there is one, current medications and labs, what's been tried in the past and why it's been stopped, any other evaluations like neuropsychological, if there's an emergency protocol. And then it should also include an assessment of what the youth knows and what their capacity is. And all of this really needs to be completed at least a year before they move on. In addition to what we've been doing nationally, I'd just like to tell you that we're trying to make it easy on everybody by incorporating it into the electronic medical record, that when somebody turns 12, 13, 14, a message pops up to remind them to the practitioner to bring up transition. And when you bring it up, there are all sorts of resources that can be printed out and given to you, the parents, and the patient with the after visit summary. And as I finish up, I want to put a little ad in for a project that I'm beginning, where we believe that we have a great idea to help at the beginning of transition, ages 10 to 14, middle school, 5th to 8th grade, to use an online program which is free to develop critical writing skills, which give the child an opportunity to think about their personal challenges to share with other youth. We will focus on increasing disease knowledge and self-management skills, and encourage expressing their feelings about living with Tourette. And if that resonates with any of you, feel free to contact the people at NJCTS or connect with me at brownla@chop.edu. So we can try to get you in. We think that this is going to really take wings and be useful for all kids with neurologic disorders, but we are starting with Tourette syndrome. For those people who feel like they really need more information, and I hope that's everyone, feel free to go to www.childneurologyfoundation.org and look for transitions. And then there's a national resource that's primarily for pediatrics and primary care, but is wonderful, and we work closely with them. And that's www.gottransition.org. So, in summary, even though it seems like transition can be impossible and it's often explosive at times, I want to remember that everybody deserves to graduate and become a full adult and benefit from all the effort we put in, and let them be happy as an adult. And with that, I'll stop and I'll take any questions. Kelly, you want to take over?
I've got it, Dr. Brown. Thank you very much for that presentation. I know that it was very informative, and I'm sure people found it very helpful as they think about the transitions of their children. We do have a few questions. It is close to 8:30. We'll ask a few, maybe go a few minutes past 8:30. And whatever questions we don't ask right now, Dr. Brown will answer in our blog. So we have a couple questions that are more related to transitions, and then we have some other more broad questions. So let's begin with more of a transition question. How often should a neurologist see a teenager with TS that is already doing CBT, so cognitive behavioral therapy, and is on medication with a psychiatrist?
Aha. So that's a really interesting question, and it could be taken in several ways. I think that anybody with a chronic condition should be seen at least 2 to 3 times a year, every 4 to 6 months. Even if they're doing well, I find that when somebody's doing well, it's often a much more interesting and deep discussion. You can peel the onion and get to some of the issues. Certainly, transition should not be the main focus when there are acute challenges. It's more for well-being when kids are doing well. But the other point that's brought up by this question is that there is no one general or general practitioner or specialist who, quote, owns Tourette syndrome. It can be followed by pediatrics, it can be followed by developmental pediatrics, it could be followed by neurology, it could be followed by psychiatry. When I've reviewed it, the majority are followed by neurology, and Only when it's really complicated with comorbidities are they followed by psychiatry. But that's not always true. It's a matter of choice. If they're on medication, they need to be followed by a medical doctor and not just a psychologist or social worker. But so the answer is that they should be seen at least twice a year and preferably a little long, even every 4 months.
Okay, thank you. And following that, similar-ish question dealing with transition. When does a parent no longer need to be present with his or her young adult neurologist appointments?
Well, we prefer that the families are there at least until the youth is 18. It's often the opposite case that even when the youth is fully adult, they come in, if they're still being seen by the child neurologist, and we have a hard time trying to talk to the young adult because the parents are so used to speaking for them. I don't think that somebody who is still in high school should be seen without the parents. And as opposed to the adult neurologist, we will typically always see the youth with the parents, but like I suggested, have time privately without them as well.
Okay, thank you. Let's see, we'll try to go to 1 or 2 more questions. We have a couple of questions that are related to medical marijuana, so not so much transition. Someone noted that their son, who is 20 years old, has had success with tics disappearing, but not so much, still having mild OCD and mood disorder. And someone asked if there is current information on current studies with medical marijuana. So I know that's not the transition topic, but if you could share what you know on that.
Well, it's not the transition topic, except I spoke about making good choices and the use of self-medication. This is a very complicated issue, which I don't think is yet fully resolved scientifically, because as you know, in New Jersey, Tourette syndrome is a condition which can justify a medical marijuana card, and that's even before the pending legislation to make it available for recreation. I do not recommend it at this point because I think that it is not clear yet about safety, both in terms of any use in the developing nervous system, but also what I know about risk-taking in general for people whose frontal lobes are not fully developed, which doesn't occur until their mid-late 20s. It's harder to stop. So I would encourage people to avoid it, but I cannot say that with certainty And I will also admit that for as long as I've been in practice, there has been an undercurrent of people who have used marijuana for medical conditions because it helps them to relax. And when you're relaxed, you have fewer tics and you're less anxious. So, but there are other ways to be mindful and other ways to avoid anxiety.
Okay, thank you very much, Dr. Brown. I think that we will stop there. There are a couple of other questions. My apologies to those of you who asked questions that we did not get to this evening, but Dr. Brown will answer them.
My apology for going on a little bit longer. When we practiced this last week, it was a little short, so I slowed it down. I apologize.
That's quite all right. Thank you. We very much appreciate all that you had to say. And we thank you for your presentation tonight, and we thank everybody for attending. And I'm going to turn it over to Kelly to close up for the evening.
Yes, thank you for joining our webinar on Outgrowing the Child Neurologist, Transition in Tourette Syndrome. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. Our next presentation, When to Worry About Your Worrier, will be presented by Dr. Jerry Bubrick and is scheduled for March 3rd, 2021. This ends tonight's session. Thank you, Dr. Brown, for your candid answers, and thank you everyone for attending. Good night.